So I'm going to be talking about managing advanced dementia and frailty. And the learning objectives are to recognize the burden of dementia, which you know, recognize the natural history of advanced dementia, and at the end of this talk, be able to identify 3 predictors of death, mortality. The other thing is to talk about domains of care, or talk about 5 different domains for goals of care. We talk about goals of care now, it's the latest buzzword, but how do you actually operationalize it and bring it into patient care and care planning? We'll be able to recognize the impact of polypharmacy on quality of life with frailty, and be able to reconcile medication use with goals of care. I want us to be able to connect those things together. If a drug is not helping someone in terms of their quality of life or improving their function, we have to ask the question, why are we using it, particularly in this setting? And finally, to recognize some common causes of agitation. So the format's going to be 3 case studies, and in some of the cases, there'll be a brief review of some of the evidence. So we're going to, and I have no conflicts of interest to my knowledge to declare. And just quickly, I think everyone knows with the prevalence that the burden of dementia is increasing in the population. We know that about 1 in 3 people in their mid-80s will have some form of dementia. They say in the USA that there's 1 new case diagnosed every 68 seconds. It's just staggering, the burden in the population. And if you think about the economic burden, there's $33 billion spent a year in Canada in 2015, $33 billion. So, and that includes both the direct care and the indirect care. If we think about people taking time off work to look after their families and hiring private caregivers. Now, most people, they used to say, survive with Alzheimer's disease particularly, but with dementia, about 8 years. We're seeing people who survive up to 20 now. People are living longer, and I think we're also diagnosing it a little bit earlier. And we know also now, particularly with Alzheimer's disease, like Parkinson's disease, there's a very long prodrome for this disease. And so when we talk about survival, we're talking about survival from diagnosis, even though most people, in retrospect, they say, oh, something was off 5 years ago, 10 years ago. And we know that unfortunately 40% of survival time is in the moderate and severe stages of dementia, when people are really severely affected with this disease. And that 75% of people ultimately end up if they survive into moderate and severe dementia, are going to end up in residential care. And we know that there's a significant deterioration in quality of life with dementia, and it's a major cause of suffering, day-to-day suffering for these people, for their families, and for the people around them. So we're going to jump into a case study. And these are all cases, people I've looked after. And with slight modifications and some of the information. So this was an 87-year-old widower who was living in a nursing home for about 3 years. And he was a retired engineer from Scotland and had a very supportive family, to the point where they hired a private caregiver to stay with him 6 hours every single day to improve his quality of life and help him, even in the care environment. And when you sort of think about assessing dementia, he had vascular dementia. And I always like to think of dementia as assessing the ABCs. So A would be ADL. So this fellow had Parkinsonism. Alex talked about that there's a spectrum of Parkinson's disease. And there are other things that can cause Parkinsonism besides Parkinson's disease, and particularly people with cerebrovascular disease in their basal ganglia and lacunar infarcts. So this fellow was wheelchair bound. He was dependent for all of his ADL. He needed assistance with feeding. His pills needed to be crushed. He was on a blenderized diet, and he was incontinent of urine. He could still get to the toilet for bowels. Behaviorally, he had agitation, paranoia, and sundowning, which was very well controlled with a tiny dose of risperidol. This guy was on 0.0625 milligrams of risperidol. It's a tiny dose. And as Dr. Henri Bargava had mentioned, that you have to be extremely careful with risperidol and dopamine blockers in people with Parkinson's, because it can make them worse. It can precipitate neuroleptic malignant syndromes, things like that. But for this fellow, just that little sniff of risperidol was enough to control the sundowning. He wasn't agitated. He was happier. The family, were in agreement that his quality of life was better with that. And cognitively, he had some mild language deficits. He had this significant subcortical dementia, with a lot of slowing. You ask him a question, and he would answer you 2 minutes later. And he recognized most of his family. He recognized his family most of the time. He had some problems with names of grandchildren, and he was, often confused, asking where his deceased wife was. Just to give you a flavor. Can you picture this guy in your mind? And anyways, he'd had 3 episodes of aspiration pneumonia in the past year, and his medications he wasn't really on very much. A little bit of thyroxine, some pantoprazole, B12, baby aspirin, and the Risperdal. And there was a call out to the on-call physician for the weekend from the nurse saying, this fellow is coughing and wheezing. He's moaning at times. He's weaker. He's much more confused. He's got some delirium. He's like a kitten slumped over in his chair. He's not eating at all now, and he can't swallow his pills. His oxygen saturations were 90%. He had a low-grade fever. His blood pressure was a little bit low at 108 systolic. He had some crackles in his right lower lobe, and he had bilateral rhonchi, whistling noises in his chest. And the question to the on-call physician was, should we send him to the ER? And what's the answer? What would you do? How many people would send this guy off? Any comments?
Well, what's his most designation?
Yeah.
We forgot, we lost the most. We can't find his chart.
I would attempt to contact the family and ask them to tell them the situation, see what they really want us to do. Is it just comfort measures? Do they want to treat with antibiotics? And that's the extent of it.
Okay, that's good. Anyone else have any other thoughts about this? Remember, he's having trouble swallowing his milk pills now too, right? He's not really eating or drinking, having trouble swallowing.
You might have the old person's friend.
Yes.
What's the old person's friend?
Pneumonia.
Okay, so, okay. His gateway to the next world. Okay, any other thoughts or comments? Yeah.
What day of the week is it? Can we rent a nebulizer or something?
Okay, sometimes, right, a little bit of nebulizer, help him with his wheezing, his comfort. It's a good question, good point. So I want to go over a study with you. I'm sure you want to hear at 7:30 at night. But this is a study that really changed my thinking and gave me some really good tools I could use about managing advanced dementia. Yeah, how many people have heard of the Cascade study? This was in the New England Journal of Medicine, I think in 2009. And I thought it was an excellent study and really very practical. So basically what it was a cohort of people that were followed for 18 months, and they were assessed every 3 months. And it was a total of 323 people who had advanced dementia, and they had to have a healthcare proxy. So they had to have a family member or someone else to advocate for them. And their average age was 85. These people had severe dementia. They used the MDS cognitive performance scale. It was 5 to 6, which is equivalent to an MMSE of 5 out of 30. So you get a sense of how impaired these people were. Most of them were GDS, Global Deterioration Scale of 7, which meant that they were completely dependent in all of their, functional status, that they didn't recognize family, they had minimal verbal communication, non-ambulatory, incontinent. And the average length of stay, they had been on average 3 years in the care facilities that they were in. And this was done in 22 different nursing homes in the greater Boston area. And they had 55% agreed to participate in the study, and they had 99% follow-up of the people who agreed, which is phenomenal, to do a study and get that degree of follow-up. So the results of the study were that 55% of people died, during the study, the 18 months of the study period. The median survival was 16 months, so that's where 50% of people were dead by 16 months. But 25% of people died within 6 months. And they found that the predictors of 6-month mortality were really 3 things. One is someone having pneumonia. The second was someone having a febrile illness. And the third one was someone with eating problems, someone with dysphagia, someone needing to be fed, right? These were terminal markers for people. And the people who had these conditions, any one of these 3 conditions had a substantially higher mortality compared to people with advanced dementia who did not have those 3 conditions during the study period. And interestingly, what they found also was that what people think people die of, you all know this, but, people in the community think otherwise, is that, sentinel events like MI, stroke, were uncommon. Less than 10% of people died from cancer, a heart attack, or a stroke. The vast majority of people died with this, at the end of their lives. And this is just a graph to show you the cumulative incidence. So if you follow these people with advanced dementia over time, this is over 600 days, so it's like almost 2 years, and this is the 18th month marker. You can see that the majority of people, their brain is degenerating, they're not able to swallow anymore, they're developing eating problems, so that by about 18 months, 2 years, almost 70% of people have eating problems, 80%. You can see that about half of the people will develop a febrile illness, and again, about 30-40% of people will develop pneumonia, and that half of the people die, are dead by that time. There's this sort of cumulative mortality. Now, the interesting part of this slide, of this study, one of the interesting parts, was that this shows the people who had first pneumonia and first febrile illness and a new eating problem. And you can see that for the people with advanced dementia who did not have pneumonia, they lived, they died slowly over this period of time. If you had an episode of pneumonia, your mortality, your survival went from 80% down to about 40%, as soon as you had one episode of pneumonia during this period. And similarly, if you had one febrile illness during this period, your survival dropped down from about 80%, down to 40-50%. And look at this curve here. People had no eating problems. Most of them were alive at the end of the study period, 18 months. But once you have an eating problem where you need to be fed and you have dysphagia and you're coughing and choking, your mortality rate, your survival drops right off, so that about 30% of these people were alive at the end of the study period. Are there any questions about that slide? Yeah.
People get full medical intervention.
Yes, they were in American nursing homes. In nursing homes in the States, they do IVs, and they're skilled nursing facilities. So I'm talking to you about the interventions in a second. What they actually did for these people. Any other comments?
How significant is febrile, like mild febrile?
Any febrile illness, included everything, UTIs, chest infections, sinusitis with fever, anything where they had fever. Okay? So the other thing that was quite interesting in the study was that I would say at least half of these people had distressing symptoms. And this comes back to the issue that, people with dementia aren't just sort of happily demented, downstairs in Oak Bay, Kiwanis. A lot of these people are suffering. And half of the people had shortness of breath. 40% of people had pain, some form of pain. 50% of people had agitation. 41% were choking and aspirating. And 39% of people in this particular study had some form of decubitus ulcers. Now, the other interesting thing they found was that 41% of people had burdensome interventions in their last 3 months of life. So they had transfer to acute care. People were being sent to acute care, even though they were going to die in 3 months. They would die in 3 months. People had IVs put in, and 7% of people had tube feeding done, which is very uncommon in our environment, but a little bit more common in the US or some other countries. Now, to me, this was really just eye-opening and not. 96% of caregivers, they interviewed the caregivers, and the vast majority said, look, the primary goal of care is comfort in this situation. But only 20% believed that the resident had less than 6 months to live. They had no clue that these people were dying. They were just basically, what are you talking about? And only 18% had received any counseling about prognosis from a doctor. Okay, so 80% of people, the doctor didn't talk to them about their prognosis. And some of it may have been people weren't aware of, these are sentinel markers for people. And that they found that the ones who got the counseling, that those that had counseling about prognosis were much less likely to have a burdensome intervention. So that the odds of them having a burdensome intervention in the last 3 months of their lives dropped down to 0.12, so they were like 12% chance of having something, being transferred to emergency, given IVs, given an NG, compared to the people who didn't. So much significant, so talking to people about prognosis significantly lowered the risk of them enduring care that's ineffective and may increase their suffering. So just to come back to our case, so this person ended up getting sent to emergency by the doctor on call. He was delirious, and when he got into emergency, one of the reasons for transfer is he couldn't swallow. Well, he pulled his IV out. He got to emergency, he was agitated, they were trying to put IVs in, and he was pulling them out. And they managed to give him, I think, 1 dose of moxifloxacin or 2 doses. He was a little bit better, and he was sent back to the nursing home the next day. And sure enough, 5 days later, even though he was on oral moxifloxacin, he relapsed. He was more distressed. He had persistent crackles in his lung. He had a low-grade fever. His oxygen saturations were 88%, and he couldn't swallow his pills anymore. And he was coughing, just being fed puree, his usual puree. So we had a long discussion with the family. This family loved this man dearly. They did not want to see him die. They just loved him to pieces. And so I spent quite a bit of time with them, and I talked to them before about it. That really our goal of care now is comfort and alleviation of suffering, and that trying to put injections and things like that are going to make it worse for this fellow. He's dying. And we ended up stopping the oral meds, gave him subcutaneous hydromorphone regularly. And I put this thing in about regular because I find in a lot of long-term care settings, people are put on PRN, and the nursing staff changes, and there's not the same follow-up. And when people are really dying, you want them to be comfortable and not wait for breakthrough pain and wait for breakthrough shortness of breath. And he had some atropine, and he died peacefully 3 days later with his family around him. Any questions about that case? Yeah.
Just you put there for the atropine was PRN. Are you a big believer in that once you start your loading dose of atropine, you need to stay on top of it Q6? Or is this something that you really can go PRN with?
You got even worse.
There's another question.
You got even worse. Atropine.
Yeah, my experience is some people it works really nicely, and some people it doesn't do anything, right? So I go, 0.6, and then I'll double it. And sometimes we'll use glycopyrrolate. It would be another drug that could be used in that kind of situation. But I think your point's a good one. If the secretions were a real problem and they were really distressing, and, often that's more distressing for the family to watch than it is for the person. I'll put them on a regular dose. Yeah, so it's a good point.
So just trying to clarify about the Cascade study.
Sure.
Because it sounds like some people actually did have advanced directives in it, and that some people weren't necessarily treated aggressively.
Correct, 20%. 20%.
If that group, that would actually skew the results, because what you're trying to find out is what the actual life expectancy is with full medical intervention. Because you're saying that their life expectancy is this amount, but you're not, if some of them aren't actually being treated aggressively, then that's not statistically correct.
Well, if you remember, about 50% of people died at 6 months who have aspiration pneumonia. Only 20% of people had the counseling and prognosis, you know what I mean, and chose more of a palliative approach.
What that study is, with some of these people, when they got severe pneumonia, were they let go?
I don't know, it's a good question. I think most of those people probably were given oral antibiotics, but they weren't transferred. And then if they did not get better, they were put onto a palliative regimen. I think that's,
So you can't really say that that's their life expectancy with full treatment, if that's what actually took place. Because a lot of them didn't get full treatment.
Well, we don't know what the individual treatments are, but we can say on average for the group. And remember, the minority of people didn't get treatment. As you were talking about aggressive treatment, the vast majority of people did get aggressive treatment, and still the majority of people died at 6 months if they had a feeding problem, if they had a feeding problem, if they had fever, and if they had aspiration pneumonia. So really what it's doing is saying that these are markers that people are reaching the end of their life, those 3 factors. That's the take-home message. That's take-home message number 1. That, if people have these, you keep that in your back pocket, and it helps counseling people to make these kind of decisions. And the second message, that the counseling is very effective for people. If you talk to people proactively, you're going to not end up in situations where people are sent back and forth to emergency. Because I'm sure that we've all had the experience where you don't think someone should go to emergency, but the family's adamant that they want them to go to emergency. right? How many people have had that experience? Right, right? So I found I do get that experience, and I find that if I can explain to them what the prognosis is, based on, my knowledge, like from the Cascade study, then they can step back a little bit and say, let's look at the bigger picture, with this person. And then I would say 95% of the time, people will back down and they'll say, you know what, he's comfortable, he's happy, he's at home, let's keep him here. And there's a good chance he may die, but, that's where it'll be. And I find that there are people who are very adamant. I will send them to emergency because I don't want someone thinking. I've had people come to me later and say, you know what, if I'd only sent my dad to emerge, he maybe have been alive for another 6 months or a year. And they're second for the rest of their lives. They think that they bumped their parent off, or were contributed to it because they were bullied into, keeping them at home, keeping them in the facility. Any other comments, or does anyone else want to share experience about that kind of situation? Yeah.
I just want to say that probably to me is one of the most important things because we really struggle with that, having people with end-stage dementia who are like CPR or, a level 3, and you're kind of like, really? And then you send them to emerge, same story, you get the emerge nurses calling you saying, why did you send this person? They're end-stage dementia. Like, that's not our choice, that's the family's choice, but a lot of times there hasn't been a lot of discussion with the family ahead of time. They just look at the form and they're like, okay, this is what I want. They don't really know what they're signing. They don't really realize that you're going to be probably breaking your ribs. They're probably going to die in an ambulance, getting CPR, or like just a terrible.
And in fact, it doesn't work.
And in fact, it doesn't work. And if they do, they're going to.
The efficacy is minuscule. Yeah.
So it's just, I feel like there's a lot of education that doesn't happen.
And
And it's just a whole huge, expensive, horrible, scenario that could be prevented in a lot of cases just by sitting down and saying a lot of those really tough discussions don't happen. I feel like.
Yeah, and most people are given a most form and they fill it out, but there's not the counseling. And that's where I think the RCI has been great to, pay doctors to spend time with families, to come to the family conferences. And that's a great opportunity to sit down and talk about, what are we looking at with people and what's the best care and how can we alleviate their suffering. Okay. So I'm going to go on to the next case. And this one is focusing a bit more on goals of care and managing polypharmacy. And this was an 83-year-old retired commercial pilot from Vancouver who was married, had a devoted and very loving wife and supportive daughter in Victoria, and a son in Vancouver. And he was transferred to residential care after prolonged hospitalization. And this fellow was well and completely independent, hiking the grouse grind until 2 years prior to his admission to the nursing home. He was diagnosed with prostate cancer with pelvic mets, and it was treated with chemotherapy, radiation, and Zoladex. And the year prior to admission, he developed this progressive gait problem and balance problem with a tremor. And he had some odd neurodegenerative disease with ataxia and extrapyramidal signs, cerebellar signs, and some peripheral neuropathy. It wasn't diagnosed, but clearly this guy was just on a really downward trajectory. And he'd fallen on a visit to Victoria while visiting his daughter. He got admitted to Victoria General Hospital and stayed in there from April till July. And his only other past medical history, this was a really healthy, spry fellow up until, he got the prostate cancer and developed this neurodegenerative disease. And his only other problem was hypertension, apparently, and he had hypercholesterolemia. He was never smoked, and he was not a drinker. It was never part of his life. And the initial assessment with this fellow, and this sort of comes to an important part, is that you need to assess these people, when they come into care. Is he had mild dementia. His MMSE was 20. His mood, he denied any depression. His short global geriatric depression scale was 0 to 5. He had some back and leg pain, but there were really no findings. He had severe muscle wasting, just generalized muscle wasting. I mentioned this neurodegenerative problem he had with ataxia and tremor, rigidity. I even wondered if it may have been a paraneoplastic problem. Severe frailty. He was non-weight bearing. He was a mechanical lift. Total care for his basic ADL. He had poor trunk mobility, and he had trouble sitting unassisted in a chair because of trunk weakness. He had very poor stamina. He could only tolerate being in a chair for about an hour, and then he said, I have to go back and lie down. I feel too weak and too tired, and I feel vertigo. I feel dizzy and nauseated. And he had severe dysphagia and coughing when he was, especially with thin liquids, and dysarthria and severe tremor and ataxia in his hand, such that he couldn't feed himself because his hand was too shaky, and he could have had trouble with brushing his teeth and morning care. He had diplopia, which impaired his vision. So this man was an avid reader, and he couldn't read anymore, which really distressed him, like reading the news or watching TV. He was incontinence in pads and had severe constipation. And he had blood pressure of 100/50, and when he sat up, it dropped down to 94/48. Severe edema, and his legs were weeping. You've seen those big, legs that were weeping, and his wife was just a basket case. So let's have a look at his medications. And this is the medication list that he was on, and I'm not joking when we saw him. Okay, he was on 17 prescription drugs, and that doesn't include his potassium, B12, ferrous fumarate, calcium, vitamin D. Okay, this is a guy who can't swallow. So he was on atorvastatin for his cholesterol. This is primary prevention. This guy never had a stroke, never had a TIA, never had an MI, never had angina, and no peripheral vascular disease. He was on 3 drugs for his blood pressure, and pretty good doses of amlodipine, ramipril, metoprolol. He was put on furosemide purportedly for the edema and his blood pressure. He was put on a nitro patch because he had severe hypertension in hospital. They needed to control it. And I'll tell you, the hypertension was because he hated the hospital so much. He remembered that event. He said someone was driving him nuts in the hospital, and he just rung a bell, and that was it. And his blood pressure went up to 220 systolic. He was on an aspirin again. It was for primary prevention. He had never had a problem before. Was on alendronate, 70 milligrams weekly for osteoporosis purportedly. There was no history of fracture, calcium and vitamin D. Zoladex for the prostate cancer, bicalutamide for the prostate cancer. Sertraline was started in the hospital because he was depressed and anxious. He was on 300 milligrams of Dilantin, and the reason is he'd had these seizures in the hospital. And when we looked at the story of the seizures, he had these fainting spells followed by shaking, which were probably vasovagal, that were happening to him, and was on zopiclone for sleep. His lab test showed he was anemic, his lymphocyte count was low, his B12 was very high, his ferritin was very high. He was being supplemented for both of those. His TSH was non-detectable, and he had high T4 and T3. His albumin was low, his creatinine urea was a bit up, he was dehydrated, and his PSA was elevated at 16. What do people think of a PSA of 16 in someone? Yeah, not bad. What level of PSA does prostate cancer spread at the moment?
40, 50.
Yeah, usually after 20. So it's very, very rare for it to spread to the bone below 20. So again, if you're thinking of planning, someone's risk of suffering, like bone mets, their PSA is 16. That's a low risk PSA. What would you do for this fella? Okay, yeah, he's on 3 drugs for blood pressure. What's his blood pressure? 100. Systolic, right? And, as Alex was mentioning, a lot of these people have that coat hanger headache. The blood pressure is low, and he feels like terrible in his head, and he has to lie down and dizzy and nauseated. Okay?
Yeah.
Pardon me?
That's probably why he's fainting.
And why he's fainting? Exactly. Great point. Anyone? Any other ideas? Get rid of statin. Definitely. This guy is not even for secondary prevention, right? It's for primary prevention.
Alendronate.
Alendronate. What does alendronate do to someone? How do you have to take alendronate? And this is a guy who can't sit up for more, short period of time, right? So it's going to burn his esophagus. Alendronate is an extremely acidic drug. It's a direct chemical esophagitis that happens with alendronate. And it could be just sitting there if it doesn't move, if it gets stuck. Okay. Anything else?
Stop the iron and the B12.
Yes, iron levels, ferritin's high, his B12 levels high, right? He doesn't need those. Dilantin? How would you handle the Dilantin? Sorry? Taper down. Yeah, so first thing I do with Dilantin, I'm always reluctant I'm very careful with anticonvulsants. Pardon me? Yeah, that's right. You would? Oh, you just stop it?
It's got a huge half-life.
Okay, that's good.
Tapered something.
So we've got an expert here. The only thing I would mention is a lot of people who may need Dilantin, you don't need 300 milligrams, and you don't need a therapeutic level to prevent seizures for a lot of frail elderly people. So 300 milligrams may make them a little dopey and cognitively impaired. Just dropping it from 300 to 200 may wake up a little bit more and have less of the side effects. And so I don't chase levels. But in this fellow's case, I didn't know that. I just tapered him off it.
Alex, what did Alex say?
Alex said that you can just stop it because it's such a long half-life. So it won't be like a rebound, Yeah.
The Olanzapine might be on that because of the Zoladex. Because that often
That's possible, definitely. So people with prostate cancer are on anti-gonadal, that are going to suppress testosterone, are at higher risk for fractures, just like people on steroids, on prednisone. So often the recommendation is to treat people with, on prednisone for more than a couple of months or Zoladex to prevent fractures. How long does it take for alendronate to prevent a hip fracture? Anyone take a guess?
5 years?
It takes 2 years. The curves do not separate for 2 years. So you need 2 years of therapy to prevent a hip fracture. So if someone's life expectancy is less than 2 years, that would be a reason to, ask yourself, do they need alendronate? But it takes about 6 months to 1 year to prevent a vertebral fracture. So if someone's life expectancy is less than that, I have no problem stopping a bisphosphonate or, but a vertebral fracture can cause a lot of suffering for people. So it's something to consider. Sorry?
How do you know how long he has been on it?
He just was diagnosed with the prostate cancer 2 years before. So my guess it's just been within 1 year. He was on no medications at all before this. He was a healthy, elderly fellow. So the way I try to bring it together is to think about his goals of care for this gentleman, okay? So I try to break it up into different domains. One is symptoms, because that's what people suffer. It's their bad symptoms that they have. The second is function. The third is medical interventions, because people have certain sensibilities about what they want done and what they don't want done, how much prodding they want, how much prodding they don't want. The fourth is survival, and right, this is completely the opposite of the way we're trained in medical school, where the top of the pyramid is survival, mortality, morbidity. Function is at the bottom. Symptoms are the last thing that when we were trained, that we were interested in. And finally, I'll add in one more domain, and that's caregiver burden. So this fellow, when you actually talked to him, he said he didn't want to be so dopey. He wanted to be stronger. He wanted to be able to sit up and have a conversation when his daughter came and his grandchildren came. He didn't want to be dizzy. He didn't want to be waking up every hour with nocturia. Constipation was a huge problem for him. It was painful. Every time he had to have bowel movement, he was phobic about having a bowel movement. He wanted to enjoy his food again. He was hoping we could help his tremor so that he could feed himself. Again, he hated being fed. He wanted, in terms of medical interventions, he really didn't want much at all. No CPR, no hospitals, no tubes. Didn't want to go out for medical appointments, like to see the oncologist, about the Zoladex. He said blood tests were okay if they were done at the home. Antibiotics were okay if they would make him feel better. That's what he said. And survival, he said, I'm ready to go. Didn't want anything to prolong his life. He said, I've had a great life. I'm done, so I'm ready to go. Now, if you look at, and he wanted to reduce the strain on his wife. Now, if you asked what are his wife's goals of care, we spoke to her. She wants to delay death as long as possible. And she wanted CPR for this fellow. We had to have a long conversation that he was competent to make that decision about CPR. She wanted hospital for any illness, and she wanted to improve his comfort. How many people have seen that sort of scenario? Yeah. And you can see, so one of the challenges in goals of care and planning is trying to converge them. Let's try to bring them together and get everyone on the same page. So this is a little flow sheet I do sometimes with people where I'll map out the symptoms, which are the goals, symptoms, function, healthcare. I'll say, what are the causes of these, problems right now? What actions are we going to do as part of our care plan? And what impact would I expect if we make a change? So for example, his fatigue, dopiness, weakness were hypotension, right? His blood pressure was low. He was over-sedated. He was thyrotoxic and he wasn't treated. So this fellow was thyrotoxic, which also was the cause of his tremor, one of the causes. And he had some renal failure. So we tapered him off the Zopiclone. He didn't need a sleeping pill at nighttime. We tapered him off Dilantin. We took him off all of his blood pressure pills. We stopped the Zoladex and the biglutamide, and we treated his thyrotoxicosis, which was causing severe fatigue. We put him on a small dose of tapazole, methimazole, and it works beautifully, for treating it. You don't need radioactive iodine, to treat this. And at the end of that, he was sleeping much better. He could sit up for 3 hours, which was great for him. And we had to put him back on a small dose of Ramipril because his blood pressure shot up a little bit to 160, 170. And there were no seizures. He did great. And you can work your way down this list. His back and leg pain, well, we took him off his statin and his pain got better. This guy had, he'd been on the statin. Sertraline sometimes, and SSRI sometimes can cause a restless leg syndrome in some people and can make tremor worse. So we actually took him off the sertraline because we weren't sure he wasn't depressed. And maybe it was because he was treated, but we took him and monitored him. He never relapsed with his depression, in the year or so that I looked after this fellow. Got rid of all the over-the-counter drugs, and his constipation, his appetite got better, like the iron and calcium and all of those drugs. So I think people get a feel for this. And then we talked about his caregiver burden and his healthcare burden. We canceled all the follow-up with the specialists. He didn't want to leave. It was his decision. He was supposed to see a neurologist, and he was supposed to see the oncologist. And at the end, his wife was much, much more relaxed. So after the cull, this guy was on acetaminophen 500 milligrams 3 times a day for pain, which he felt helped him. We took him off it. We weren't sure if we were just giving it to him, and he felt he was more comfortable with it. And he was on a small dose of methimazole, and that was it for the thyrotoxicosis. So 9 months later, this man developed progressive dysphagia with recurrent aspiration pneumonia. Had multiple meetings with his wife. She wanted treatment with antibiotics. He could take it or leave it. And we treated him, and then eventually they stopped working, and he got to the point where he couldn't swallow, and had a long talk with her. He was adamant he did not want to go to hospital. And we commenced end-of-life treatment, and he died the next day with his wife and daughter with him. And that was how we handled this case. Any questions at all about that sort of polypharmacy and converging goals of care? Or comments? Yeah.
Well, I think the first thing is that I notice you're very careful with tapering some. The ones you could stop, you stopped. But you're careful to taper, and I think that's the thing that when we do have these people and we do want to get them off that treatment road, that we have to be careful that we don't go too quickly and too fast. That's the only thing I noticed there.
Yeah, I think you're making an excellent point. Some people need drugs. People with heart problems, heart failure, they need 5 drugs. You take them off and they get pulmonary edema and they're sick. So we need to be careful, particularly with the cardiac drugs, some of the neurological drugs, the Parkinson's meds we talked about and other neurological drugs. So I think your point is good, is, the ones that you don't anticipate a problem, take them off it, the low-hanging fruit. You can get rid of that quickly. And then the other ones you can taper, and it actually took us about 6 weeks to get him off all of his medications, systematically. So, probably 6 to 8 weeks in total to get him off everything. So it's a very good point you're making. And always we reassess people, because sometimes we think that we're making them better and they're worse. So, and I always leave a message in a chart with the nurses: if they're worse, if their pain gets worse, if this gets worse, they have more trouble breathing, go back on the medication. Just go back to where we were. So we took, I'm looking at Janice. We had a lady who was on memantine with, advanced dementia and stroke, and, and this lady's closer to end of life, and, she was still on memantine. I thought, what is this drug doing for her? At this stage, it's expensive. It's not covered by pharmacare. We took her off the memantine. She was way more confused and had trouble having conversation with her daughter, and that was their, the focus of their life at that stage. Put her back on the memantine, right? How much time do we have, Ian? I just don't. Okay. Do we have time for one more case? Sure. Go ahead. Yeah.
What was the cause of the dysphagia?
Oh, he had this neurodegenerative disease. So he had almost like not ALS, but people who develop so multi-system atrophy. Yeah, autonomic problems. He was very sensitive, right? And he had ataxia, cerebellar signs, and he had extrapyramidal signs. So he almost certainly had a multi-system atrophy. That's right. And with that, people get dysphagia. And most of these people, like most people with Parkinson's, die with dysphagia, and aspiration pneumonia, will be the cause of death. So the last case I want to present is a case of agitation in someone with advanced dementia. So we've talked about someone with aspiration and prognosis. We've talked about polypharmacy and goals of care. And we're going to talk a little bit about agitation. And this is a lady who we looked after at home till her end of life. And she was an 85-year-old widow, lived with her daughter and son-in-law in the downstairs suite of their house. She was one of Idi Amin's refugees who was kicked out of East Africa in the 70s. She was a educated woman. She spoke 3 languages. She'd completed high school, worked in a very successful family business in Uganda. Then they built up, they started with nothing in Canada and built up another great business. And she had advanced Alzheimer's, a mix of Alzheimer's and vascular dementia. Her MMSE was 0. She was at the floor. You couldn't measure her cognitive function. She was completely dependent in her care, currently needed a mechanical lift, and she needed to be fed. And her family were really committed to keeping her at home, and they had actually hired 2 24-hour live-in caregivers, which was very expensive. And her past medical history, she had this mixed Alzheimer's vascular dementia. She had lacunar infarcts, depression, diabetes, hypertension, previous MI, reflux, and osteoarthritis. And these were her medications. She was on Zopiclone to help her sleep at night, 7.5 milligrams, 75 milligrams of venlafaxine. She was taking Risperidol, 0.25 milligrams twice a day. And if she didn't have it, she was crying all day and crying all night and hallucinating and looking for her mother and very distressed. And with the Risperidol, that sort of reduced that to, she still talked about her mother, but it didn't bother her anymore. And she was on memantine, 10 milligrams BID. And if she was off the memantine, this is one of the people that had helped. She couldn't follow any instructions, for her ADL care, like put your arm in here, and, she couldn't really carry anything out. And she was on 10 milligrams of amlodipine. I'll just mention that, for some people, with the blood pressure, when her blood pressure, she was off amlodipine because I was wondering what it was doing. Her blood pressure went up to 190, and she got more confused with that blood pressure. So we put her back on the amlodipine. And similarly, she was on 5 units of Lantus insulin. And if we took her off insulin, this was like a type 1 diabetic. She'd been diabetic so long that she completely burned out her pancreas. Her blood sugars would go up to 28 to 30, and she would be weaker. She would be unwell with it, right? So it wasn't just treating her blood sugar. She was physically unwell when her blood sugars were with hyperglycemia. So we ran some problems with her. She had a relapse of her, her BPSD, or behavior and psychiatric symptoms of dementia. She was calling out. The caregiver was up all night, and they were exhausted, and they were going to quit. She was anxious when she was left alone. She was crying and sobbing, looking for her mother. She was screaming whenever they did care with her, which was a change for her. And they thought maybe she was in pain. They said to me, and they thought maybe she had like really arthritic knees. And she was a little bit more peaceful when her daughter was present, and she was comforted by holding plush dolls. So I think you guys have seen people like this before. The only thing to really see with her, she had OA in her knee, she had some earwax, and she had some dental problems. Her labs were unremarkable, and the situation was not sustainable. The caregivers were going to quit. The daughter was in tears. Okay, so we went back to what are the goals of care for this lady. And number 1 was relieving her distress. She was distressed. She was agitated and screaming and miserable. Survival, they don't want anything that would hasten her death. So they came from a Muslim family, they were religious, and felt we're not going to do anything that's going to make her die more quickly, but at the same time we're okay with death naturally happening. They wanted her to die at home. The daughter promised her that she would never put her in a facility, but they needed to be able to do her care. And the live-in caregivers needed to be able to sleep. If they couldn't sleep, the whole thing was like a house of cards. And they didn't want any transfer to hospital. They were terrified. Last time she was in hospital, she got really agitated, really delirious, and it took her months to calm down after that. So what would you do for this lady? What do you think how would you approach this problem? Any ideas? This is a crisis, right? Caregivers are going to quit, and this is the truth. This is what happened. Anyone have any ideas how we can manage her? Opioids, right? So pain, right? They think she's in pain. I listen when a caregiver say they think she's in pain, especially when they're handling her, that there's pain. I would think maybe there's pain. So I want to just, how many people are, I want to just show you very quickly, this was a randomized controlled trial from Norway where they clustered nursing homes, randomized them to either stepped analgesia or usual care, which was antipsychotic treatment for people with agitation and dementia. In the randomization, they did 4 tiers. The first one was acetaminophen up to 3 grams. Then they would add in morphine up to 20 milligrams. Then they would use a buprenorphine patch, you know, the Butrans patch, up to 10 micrograms. And then they would add in pregabalin if they thought there was a neuropathic component, or they got usual care. And this is the results of the study, you know, at the end of 12 weeks. And this is the control group. And they used something called a Cohen-Mansfield Agitation Inventory, and it's used with dementia for, you know, it was used for assessing risperidol and BPSD. It's a very good test. And you can see that in the group that was treated with the stepped analgesia protocol, their agitation levels went way down. And you can see that the people who got usual care, there was no change in their agitation level, okay, compared to the usual care group. So, and that the treatment effect size was the same as the CAT study for risperidol versus placebo for treating people with dementia and agitation and psychotic symptoms. So it had the same benefit as risperidol without the side effects. So coming back to this lady, what did we do with her? Well, we cleaned out her ears to make sure she could hear what was happening. We got a dentist to come in and do some tooth extraction. She had painful rotten teeth that needed to come out. We tried tapering her off each of her medications just in case they were causing side effects, and it didn't make a difference. We added an acetaminophen up to 1,000 milligrams 3 times a day. There was slight improvement with her. Injected her knee with triamcinolone, which improved her capacity to transfer in with care, and that got a little bit better. And we put her on buprenorphine 5 micrograms, which she seemed to tolerate. Every other narcotic we tried with this lady was problematic. So hydromorphone caused worse confusion at 0.5 milligrams, and she became impacted with stool despite us sort of trying to get ahead of it. Tiny dose of Sufenta, which is very good for incident pain with care, ADL care. You give Sufenta sublingually for people. It works quickly. It doesn't last as long. This lady slept for 10 hours after 2.5 micrograms of Sufenta. You know, so that was a bust. They weren't going to try that one again. And fentanyl patch she was better, a lot better, but even 6 micrograms, but she was over-sedated and sleeping most of the time. So just with the 5 micrograms of buprenorphine, calling out stopped. She was sleeping through the night. She was okay with her ADL. We were actually able to taper off the risperidol. She didn't need it anymore. And we reduced her zopiclone to 3.75 milligrams, so it was like a bonus, just treating her pain, you know, once the penny dropped. So things were great, and we thought, wow, this is just great. And then 6 months later, it came back again. So the agitation came back. It was escalating. She was calling out, and she was crying. She was crying at night whenever they turned her or moved her or did something to her. Anytime they did any kind of care, she would cry. And with all of her transfers, she would scream. What would you do for her at this stage? Anyone have any ideas? Yeah, so she had trouble with hydromorphone, which is a little bit better tolerated than morphine, 0.5 milligrams, but you could try morphine. Increase the buprenorphine, good. Anything else? Exactly, so you want to examine her just to make sure, like you see people, and I've seen people with incarcerated hernias, you know, that were missed, you know, and pressure sores. So you do a good physical exam and everything with her. So we increased the buprenorphine to 10. She couldn't tolerate 15. There was a very slight improvement with the buprenorphine, 10. And I did a physical exam. I went and examined her again. I just thought, you know, I was checking. Remember, I put a blood pressure cuff on her. She just screamed. And then I sort of kind of went and held her, and she screamed again. And when I took my hands off her, she didn't scream. And then it sort of like the penny dropped with me. Maybe this lady has PMR, polymyalgia rheumatica, and we got a CRP on her. You know, I checked her thighs were tender. All of her muscles were exquisitely tender. And we put her on 15 milligrams of prednisone. The calling out stopped. Like 24 hours later, it was gone. Completely gone. She could do her ADL. They could do it again. There were no problems with the transfers. We ended up, she was diabetic, and her blood sugar started going up. So we switched her to injectable Depomedrol, and we, you know, gave her 120 milligrams, which is equivalent to like 5 milligrams of prednisone per day, and we're giving it every 3 to 4 weeks for her. And that lowers the steroid dose significantly and lowers the side effect levels significantly. And we went back to the 5 micrograms of buprenorphine because she still had osteoarthritis too, and had other reasons for pain. Any questions about this? And this is a very challenging case, isn't it? When you see people, and again, to just reinforce the point that there are multiple things that can cause pain in these people, and it's hard when they can't communicate with you. It's hard to communicate, and we need to think about the different causes. Often most chronic pain in my patient population, they've got 4 different causes of their pain, not just one cause, and you need to deal with all of them, to have a successful outcome and be thorough. Any questions about the case before I move on to conclusions, finish up? Okay. So just in conclusion, advanced dementia is a palliative diagnosis. We need to think of it that way. If you think about the 6-month mortality is about 25 to 40%, median survival 1.3 years. That's the same prognosis as metastatic breast cancer. And it's the same prognosis as people class 4 congestive heart failure. It's a fatal disease. It's a fatal problem. Second take-home point is that most of these deaths are predictable, and they're not precipitated by out-of-the-blue acute events like an MI or a stroke. I mean, people do get MIs, they get strokes, they have other things that happen. But most of these people, they die from aspiration pneumonia, a lot of these people. And infection, their immune system is shutting down too. Urosepsis, recurrent urosepsis. And the third point is that they're really, if you can remember these 3 sentinel predictors of 6-month mortality, once someone needs to be fed, and we're not talking about people need to be fed who are with it, mentally with it, or early on, or they have MS or something like that. We're talking about people with whose MMSE is 5 and below, where their brain is at the point where it cannot get the signals to their throat anymore, right? Those are the people we're talking about. So not everyone who needs to be fed has a prognosis of 6 months, as survival of, median survival 1.3 years. But if you do have advanced dementia and you have a feeding problem, pneumonia, or febrile illness, that's something you can then go back to the family and say, we need to talk, about what the next steps are going to be. Distressing symptoms are common in this condition. They're underreported and they're undertreated. And if you take the time and speak with caregivers, educate the caregivers and their proxies, establish goals of care of people. What do they want? You can prevent these burdensome interventions and aggressive care, and you can improve people's quality of life all around the table. The patients, the residents, their families, the staff, so everyone isn't, running and jumping. Think of goals of care in domains. We talked about symptoms, which is quality of life, function, healthcare, caregiver burden, survival. And survival, I don't want to dismiss survival. For a lot of people, survival is important, but we need to make it explicit. What do people want? What do they expect? Review the medications and make sure they're consistent with their goals of care. And I would say for a lot of the preventive treatments, you could probably get rid of them. Like think about an ACE inhibitor for preventing diabetic nephropathy. How long does it take to develop that? 15 to 20 years, till people get renal failure from, protein in their urine. So do they really need to be on, Ramipril, when they're in a residential care to prevent neuropathy? Similarly, anything that's causing an adverse effect and is not tolerated by people, think about metformin. It causes severe anorexia in some people, and nausea. And their quality of life is being diminished because they want to enjoy their food, but they don't enjoy it anymore. So think about the trade-offs that you need to make. Individualize the goals of care, the interventions, and synchronize them with the patients and the care team, healthcare workers, and family caregivers. Cautiously use palliative medications in these people, even if they don't have cancer. So, people with an advanced dementia may not be able to communicate their pain or breathlessness, and they may just yell or scream or writhe or withdraw. I like to think of it as palliative as you go with people. It's not mutually exclusive. There's good studies that show that palliation plus chemotherapy and oncologic care has better survival than just pure chemotherapy and radiotherapy without the palliative care. So people do better with palliative care plus treatment, active treatment. And treat their pain, treat their dyspnea, treat the constipation, treat their itching, treat their depression. These are things that drive people crazy. and make their last days not very good. I would always also recommend deploying end-of-life backup orders, especially in a facility environment, because it's hard for the nurses when, on the weekend, suddenly someone takes a downturn and they don't have orders. They can't give them a painkiller. They can't give atropine or something like that. So to have those in place for people so they can move with them. And finally, I'd say is mobilize the resources. There's great teams and facilities with PTs and OTs and social workers. Just positioning someone better in their chair may reduce their agitation. Someone who's in a wheelchair. I mean, I would go nuts if I was sitting in a wheelchair all day. So I'll stop there, and I'm not sure how much time we have. If there are any other questions at all, I'd be happy to answer them.
Ted, I think you hit the nail on the head in terms of, the important work around helping families understand the natural history of these illnesses that we see in late life. And I'm wondering, I think we've taken a good step at the Kiwanis Pavilion in our annual care conferences with always taking a few moments at the end of a conference to look ahead together and talk about what have we seen in the last year and what might we see coming up, and helping to prepare families for what they might see ahead. But I'm wondering, are you using any of the frailty scales or any other tools that help to sort of place the big picture?
Well, most of these people are extremely frail by definition. So I mean, there are pain scales you could use, right? There's Abbey pain scale and McGill.
Like the frailty scales, like the guy from Halifax?
Oh, well, these people are all frailty scale 8, 7, 8, and 9. So it doesn't really help. Sort of like a bottom note, MMSE 0 now.
Yeah.
So they're at that. So it doesn't, I don't find it
So you don't find that
useful.
helpful?
No, but there are pain scales you can use with dementia. Is anyone using any pain scales with their people with dementia in facilities? Anyone? Any of the nurses? Yeah, which scales are you guys using?
The PAC Slack?
Pain ed?
Pain ed? Okay. Anyone else? I think there's something called the Abbey pain scale that's pretty good, and McGill pain scale, as well. But I think it's good to have that where the staff, the care workers, or the frontline people fill them out on shifts. And that's one way you can track pain with people too. Any other comments? Yeah.
The facilities in Victoria are moving more as a whole towards getting CPR policy. I don't know. We don't have one, but I know I've heard other, I think OK Lodge has one. I'm not sure what the trend is for that, but it's really.
Yeah, I think Fiona probably is the director of care at Kiwanis and was at Broadmead. You're like tied into that. Is there any move at all to get a blanket no CPR?
Yeah, VIHA has a great policy. Everybody should just stamp their own on top. We don't offer CPR. We're not required to offer CPR. If someone wants CPR, then we would advise the family that we would call 911. If a caregiver was able to start CPR, they would, but otherwise we would just be calling 911. And in the absence of a decision on a MOST, we're not required to start CPR. I think that's what the clinical order set says.
Yeah, so I think the default is no CPR. And then unless someone says they want CPR, and then they still don't do it in the facility, they call an ambulance.
But the ambulance will do it if you don't have a no CPR on the chart.
Yeah.
Unless you have a MOST, now everybody should have a MOST, and the no CPR order is part of the MOST, right?
Right, but what I'm saying is if they don't have some people refuse to fill it out and they haven't gone around to it or whatever, in that instance.
Then they have to do CPR if they come into a facility, and regardless of what your facility is, if they have to do it. I have a lot of friends who are ambulance worker. I've worked in the hospital for a lot of years. If they come upon somebody, there's no MOST, there's no nothing, it doesn't matter. If it's not a stamped, signed, notarized thing, they automatically have to do CPR.
Trick is don't call them.
Don't